Hello, everybody, and welcome to this quick lecture on everything you didn't know you wanted to know about kidney stones. So let's get started. Here is the classic presentation of kidney stone presentation. Sorry, that's a lot of presentation all at once. But what you can see is that this is usually a unilateral, so one side or the other, flank pain. And usually these people experience intermittent waxing and waning pain that causes such a deep pain response that they get nauseous or can even vomit because of the pain. Usually this pain, if it gets bad enough, can radiate around into the abdomen on that side or can even go down into the genitals. Specifically, the testicles can feel the pain as well as the flank. Usually patients will complain of something like dysuria, pressure when they pee, or not able to pee, and even though they're trying. Usually no position is comfortable. As a matter of fact, in the ER, we talk about a stone dance where the people pace across the room over and over, and no matter where they sit or stand, they just can't get comfortable. The greatest mimic of kidney stone pain is a AAA, right? An abdominal aortic aneurysm. We also see this true in abdominal aortic dissections. So if this isn't quite exactly the classic presentation, or if the person in front of you is having a lot of symptoms that could be related to a aortic problem, always consider this. This is one of the biggest mimics in the emergency department. Now, here's a quick bonus question. Why does stone pain radiate to the genitals? So this is kind of embryology, but it's pretty cool. When the kidneys and the genitals, whether it be ovaries or testicles, are created in the womb, they're actually made from the exact same tissue right next to each other. And so as the nerves are forming, it's actually the same nerve clusters that innervate both the kidneys and the gonads. And then as the fetus and the embryo develop, slowly over time, they move to their appropriate positions. The kidneys a little bit higher and the genitals lower. So this is actually the same nerve cluster. And that's why it appears that the kidney pain radiates to the genitals. And sometimes, as a lot of males would know, the genital pain, like if you get kicked in the balls, can actually radiate to the kidneys. Because again, same nerve. Very cool. All right, so we're going to keep this lecture a little bit short and sweet because this is something that we see so commonly, and because our patients have so many questions, I want to make sure that you understand all of the basics and can answer those patient questions. So we're going to talk a little bit about the pathophys. We're going to talk a little bit about stones and what they are in general. We're going to talk about the treatments specifically for ER. And then we're going to talk about some complications and preventions. All right, little bit about pathophysiology of stones. How do they form? So they're always forming in the kidney. They do not form in the ureter. They do not form in the bladder. Bladder stones and kidney stones are separate. The kidney is basically a big filter. So if we have too much of some particular thing, or if we hyperconcentrate a waste product, that is going to develop into a stone. High levels of oxalate, calcium, and phosphate are usually the most common things that stones are made from. And this is what precipitates in the kidney and then becomes a stone. Once that kidney stone is formed, it may go down into the ureter and cause problems, but it also might never, which means that just because you have a kidney stone seen on a scan and it's still in the kidney, it may never actually come down in your lifetime, or it might. And there's no way to predict this. This is all based off of luck. And as far as I know, there haven't been anything that has showed whether or not the kidney stone will come down or not. In the bladder, once the kidney stone has reached the bladder, that is, there is significantly less pain. So it's important that you know that the kidney stone hurts basically on its travel through the ureter and not once it gets into that bladder. This is because the bladder tubes are significantly larger than the tube of the ureter. All right, a couple of other things that you should know. Kind of talked a little bit about this in the last slide, but you can see non-obstructive kidney stones or nephrolithiasis. You can see those in these first two pictures on the slide. The red arrow is pointing to a stone that's still located in the kidney, and that X-ray shows a kidney stone still located in the kidney in a very similar spot. These stones do not cause flank pain. Let me say that again. These stones, when they're not obstructive and they're still in the kidney, do not cause flank pain. So these stones are not something that we tend to worry about. While it is something that patients should maybe know about, that they could or may not have kidney stone type pain in the future, we can't predict. So a lot of times these are incidental findings that we find on CT scan or X-ray that we generally often don't mention to the patient because we can't predict whether they'll ever experience symptoms or not. However, these two images on the other side are obstructive kidney stones or ureteral stones. A lot of CT reads will call them ureteral stones. So these are the stones that are actually in that ureter that are going to cause the symptoms. Now, this isn't exact because everybody's anatomy is a little bit different. But imagine the urethra, the tube that goes from your bladder to your exit hole. And that is about the size of a regular straw, right? A McDonald's straw when you get a Diet Coke, right? So it's not the biggest, but it's also not the smallest. In comparison to this McDonald's straw, the ureter is actually about the size of a coffee stirrer straw. And so with those two reference points, you can understand why it hurts so dang much when those kidney stones go through and stretch that ureter. And you can also see that it's very easy to cause some obstruction as they go down. You can see the widening or dilation of that ureter, and that can often cause your hydroureter that we see so very frequently. So the symptoms start when the kidney stone is in the ureter, okay? We'll talk a little bit more about this a little bit later on. Let's first talk about the different kinds of kidney stones. And that's right, there are a lot of different kinds of kidney stones. Almost all of them are related to calcium stones. But you can see when I say calcium stones, I'm actually referring to 3 different kinds of stones as listed here. Now, again, because we're not in pathology and because we're not the ones evaluating these stones under the microscope, we tend to kind of understand that there are different stones and kind of move on. But it's really handy to be able to answer patients' questions when they ask if they should do a strainer or not. So you could see that cystine stones are the smallest type or the least common type. And that's because they're almost exclusively related to a genetic disorder. You can see that uric acid stones are pretty common, and you don't have to have gout to have uric acid stones. These are actually very commonly associated with diabetes. And then, of course, there's the struvite stones, and we're going to talk a little bit about those later, and then all the 3 different kinds of calcium stones. So let's talk about each type of these stones individually. Okay. Here is another example of all the different kinds of stones, and I wanted to make sure to make the point that strainers aren't needed for a one-time stone. It's only those people who have frequent stones that we need to send those off to pathology for, because if you're having stones every couple of months or even every couple of weeks, that's probably too many, and we might need to see if there's a genetic disorder or something else that we need to be treating. So you do not have to give a strainer to every patient with a kidney stone, but when you start hearing that they're having very common stones, that's when I start giving strainers and at least telling them to take them to their PCP. All right, let's talk about struvite stones. To me, these are some of the most intricate and intriguing stones. These are often called infection stones or staghorn stones. And you can see that they're called staghorn because they actually form in the entire calyx itself. And that calyx, it kind of makes a weird staghorn. I guess it looks kind of like an antler. And because these are so large and because they're stuck in that calyx there, these almost never come out. They're too big to go down the ureter, right? So these are very commonly associated with urinary tract infections, specifically urinary tract infections that are caused by a somewhat rare urinary tract bug called the Proteus mirabilis. Proteus infections are hard to find on a urine analysis. As a matter of fact, usually the only clue to it is the fact that your pH is kind of alkaline, and it's more alkaline than it should be for urine. So the only way that we can detect these, especially in the emergency department, but in all of medicine, is usually by getting a urine culture and having them grow out of the urine culture. So if you're hearing a lot about staghorn calculi, or you see some patients with repeat kidney stones that happen to have a staghorn calculus, it's worth it to send a urine culture every time in all of your patients that have struvite stones. Also, consider strong antibiotics for at least 14 days if you're starting to be suspicious of Proteus mirabilis, because your typical 7-week course is not going to be enough. Now, cystine stones, remember that these were the most rare of all the kinds of stones, and they're also the smoothest. And that's because it's all about a genetic condition. And these cystine stones, they crystallize very beautifully and very smoothly. So typically, cystine stones are a big bad situation if you find these patients with a history of cystine stones, because they tend to have chronic kidney disease later in life. You can also have multiple stones that build up. And there's a lot of other genetic factors that go into this one. So it's just handy to know that genetics definitely play a factor in this particular stone. Next is the calcium oxalate stones. These are the most common of all stone kinds. They're also the most preventable because the most common cause is usually dehydration. We're going to talk a lot about that a little bit later. But I also want you to notice and compare this kind of stone to all of the previous stones that we've already talked about. Look at how pokey this is. Look at how sharp and angular. I wouldn't want that to go through my ureter. These are tending to be the most painful kind of stone because, unlike the cystine stones, which are nice and smooth, and staghorn stones, which don't really go down the ureter because they're so big, don't get me wrong, those still hurt. But these stones are sharp. They're angular. They're not nice, clean river stones. And so as they go down the ureter, they tend to scrape the sides of the walls and poke and prod and be very painful. These cause a lot of ureteral spasms and can cause your ureter to bleed, which is why we have hematuria in our urine. There's a lot of different causes for these calcium oxalate stones, and we're going to talk about those a little bit later, but I just wanted you to kind of compare the look of this stone to other stones. Last but not least is a uric acid stone. And you probably will see at least one uric acid stone, although you may not know it for what it is. It can be gout related, but remember that it's not always. We've also started seeing uric acid stones in people who are eating these really high protein diets. So think about the bodybuilders who are eating something like 200 grams of protein a day. These are the kinds of stones that those bodybuilders tend to make. I don't know if you've ever heard of those, but now you know. All right, here's a little bit about ureter anatomy. And remember how I told you about how small the ureter is. So you can see the renal pelvis, or the calyxes up there, where the staghorn stones will form. And you can see that if it's forming in each side of each branch of that renal pelvis, that's why it looks like a staghorn or some kind of antler. Now, there's a couple of smaller areas that stones tend to get stuck in. So I want to talk a little bit about the upper third, the middle third, and the lower third. So we have these three spots. So we have a ureteropelvic junction, or UPJ, right? That's all the way up, not in the kidney, but it looks very similar to being in the kidney. So you have to be really careful with that, okay? Anything that's in the renal pelvis can cause pain. So those staghorn stones, those are hurting. You can also have really large stones that are so big that they can't go down into the tube. And so they get stuck in the tube squeezes, and then they come out. They get stuck in the tube squeezes, and then they come out. These people can have problems with kidney stones for years, and it's the same stone. So not the best for the patient, but eventually those stones have to be surgically removed because they're going to continually have pain until that stone is out. So that's the first area where stones will get stuck. And we're going to talk about sizing in just a moment. The middle third runs along next to that common iliac artery and our aorta. And so typically the middle third tends to be a small relief. If the stone was small enough and was able to stretch the ureter, causing all of that spasmy pain to go down into this ureter, the middle third is usually where patients get some relief. Then we go over that common iliac vessel. This is when, if you remember anatomy, that those ureters and the blood vessels are diving deep into the pelvis. That dive going in and down causes a narrowing. This is another area that stones get stuck at that causes a lot of cramping, a lot of spasming, and a lot of pain. Finally, we get to the ureteral vesicle junction, or the UVJ. This junction here is right before it pops into that bladder. I'm talking like seconds before it gets there. It is the smallest part of the tube, and this makes it the number one narrowest place and the place that almost all stones get stuck. And for some reason, this area is where we're going to see or image a lot of our stones. So if you have to guess where the stones are, these are the three places that you would want to image or look for stones to be able to determine where the stone is, which one's causing pain. I would almost always bet a lot of money on the fact that if it gets past that UPJ, which is on that upper third, then it's going to be stuck in the UVJ. And you guys will get used to hearing about that. And that's why I put an asterisk next to the UVJ, because that is most commonly where those stones will be stuck. Now we can finally talk a little bit about stone sizes. Now, I'm not as familiar with a lot of these millimeters and centimeters, so I really like to visually see a graphic. And that's why I've included for you this really handy graphic that somebody else put together, showing you what different millimeter sized marbles, or maybe these are metal balls, look like. These are actual size, obviously I blew them up a little bit, but the more 1 millimeter a stone size is, the longer that it has I guess I would say the harder it is to pass. So you could imagine that a 10 millimeter, aka a 1 centimeter stone, doesn't pass very easily. It has to stretch the ureter quite a lot, or maybe even go into a ureter that has already been stretched by previous stones. And it has a lot higher of a chance of getting stuck and then not being able to come out. I'm talking ever. I'm talking months and months and months. And that does happen to some people. That usually ends up requiring surgical intervention. And so for us, the size of the stone actually matters and is useful information to tell the patient, so we understand whether or not the patient needs to be a surgical urology referral or not. So if you look over here, we have a general rule of thumb. Now remember, the patients don't read the book and they don't know this rule. So some patients will shockingly pass a 1 centimeter stone like it ain't no problem. And some patients can't even pass a 3 millimeter stone. So it's only a rule of thumb. But the typical rule of thumb is that when we measured all of the stones and how much percentage of people passed them, what we found is that 5 millimeter stone is the cutoff. 5 millimeter stone or larger is when we call urology and ask them if they want a surgical referral. A lot of our urologists just tell us, we trust you, we trust we trust the radiologist to measure accurately. So don't call us every time there's a 5 millimeter stone. We just automatically refer to kidney stone clinic. Now, I realize not ERs are made equal, so not everybody is going to have that option. But you should know that 5 millimeters is the cutoff. And the reason why it was made that way is because they pass by themselves 50% of the time, which means 50% will be fine over about a 24 to 48 hour period, and 50% will not pass and will require some kind of surgical intervention. And that's why that was made as the 50% cutoff. That means that if you get bigger, your chances get about 10% smaller with every 1 millimeter. So a 6 millimeter only passes 40% of the time. A 7 millimeter only passes 30% of the time. You get the idea here. That said, remember that this percentage is not a 100% guarantee, okay? Like I said, people pass 2 millimeter stones or 20 millimeter stones. It's all been possible. Okay, this is just a general understanding, especially for a patient who's brand new to kidney stones. So if they're a 5 millimeter or less, typically I send them home and say, your chances are good that you're going to pass this within 24 to 48 hours. And if they don't, then here's the number to call. Here's the urologist's office. Okay. If they are above 5 millimeters, I send them to our urology clinic where they end up getting a discussion about if they can't pass it within a certain amount of time, do they want a surgical intervention? Here's a couple of really interesting fun facts, just because I get tired of going on and on. In 2004, the largest stone ever recorded was in India, and it was 13 centimeters, and that was successfully passed without surgical intervention. Very cool. The most stones passed, according to, random internet websites, was 5,704. And that means somebody had to count them. That's quite a lot of stones. I think that guy had a genetic problem, or girl, whoever it was. In 2017, the heaviest stone, at least according to record, was 4.4 pounds that was removed from somebody's kidney. That is definitely an American, and I guarantee you that had to be surgically removed. There's no way. Napoleon, like not Napoleon Dynamite, but the actual dude from France, we think he actually lost the Franco-Prussian War, which was one of his biggest defeats in his career, due to a painful kidney stone where he couldn't think very well during several key battles. And he died later during a kidney stone surgery. So we think he was plagued with a lot of kidney stones. So fun fact, kidney stones play a big role in history. Now let's talk about diagnosis of stones. So diagnosing stones is a clinical diagnosis. And I know that you've heard this term plenty of times, but that means that we don't need to do any testing. If it sounds like a kidney stone, if it smells like a kidney stone, if the patient tells you that it's just like their previous kidney stones, you don't have to order any labs, anything. You can give them the medications and you can send them home. However, typically most folks will order at least a urine to make sure that there's no associated infection. And this is because typically infected kidney stones are one of the most commonly missed big deal complications in urology. That said, you also have to know that a lot of our students think that we're ordering a urine to look for hematuria. And remember that I told you that calcium kidney stones are really pokey. And so as they roll down that ureter, they can cause all of that scraping and bleeding, which does end up rolling down into the bladder and makes it look like they have microscopic hematuria in the urine, which is true. They do, especially because of all that scraping and all of that stretching that the ureter has to do. But 20 to 30% of those stones either scraped so high up that the blood can't get down into the bladder, or they're not causing bleeding. And just because it's not sharp or pokey, and just because it's blocking that blood from getting down into the bladder, doesn't mean they don't have a stone. So this is a pretty high percentage, 20 to 30%. One out of almost every 5 people doesn't have blood in their UA. So this is not a way to diagnose kidney stones. Very important for you to know. Also, don't forget about that urine culture. If you're going to get a UA, go ahead and order that urine culture, because in case you do find a struvite stone, or in case that infection is present, we want to know what kind of bacteria it is that's causing this issue, right? So beyond blood labs, I often have students talk about BUN and creatinine, and they always want to order a CBC looking for low blood counts, and they want to order a BMP because they want to find out if the BUN and creatinine is bumped. BUN and creatinine in a typical kidney stone is not elevated. Why? I know you can do this. The answer is because we have the other kidney. The other kidney will handle the clearance when one kidney is gone. So the BUN and the creatinine is almost never elevated in a one-sided kidney stone. Now, let me ask you this. What if you only have one kidney? Like in this example, there's a horseshoe kidney. So if you only have an obstruction in one side, would that be a problem? Heck yeah, it's a problem. If you only have one kidney and we're obstructing it to where you can't pee or make urine, that's going to ultimately cause kidney failure. And that means that if we don't do anything about it, you're going to go into dialysis and you're going to have kidney failure. There's going to be a lot of problems. That's going to be a lifelong issue. If you only have one kidney and a kidney stone or any kind of obstruction, that means that you 100% need to call urology. Now, some people argue about this horseshoe kidney because even though it's only one kidney working together, if there's only a kidney stone on one side, it can still empty out on the other side. So a lot of people are not very impressed with a horseshoe kidney, although I personally would still call urology and make them tell me that. There's another really big deal for a kidney stone where you only have one kidney that you need to call urology on. Any ideas? Transplant kidneys, big deal. Even if you have kind of the atrophic kidneys or the old kidneys that aren't really doing anything inside that person, if you have one transplanted kidney that has a kidney stone, that's the same thing as a person with one kidney. And we don't want that transplant kidney to die. We don't want to put that person back on dialysis. So that's an emergency. You need to call urology. You need to either admit that person or transfer that person to somewhere where there's transplant surgery. So transplanted kidney stones, big deal. One kidney in a person, very big deal. Okay. Now, when do we order imaging? I just told you it's a clinical diagnosis. So you can order a urine and a urine culture, but we don't typically order labs for typical kidney stones. So when do we order imaging? The answer is whenever we suspect some other diagnosis. And it has to pass a certain threshold for you and your experience and your comfort level to be able to say, I'm pretty comfortable saying this person probably doesn't have a AAA or a dissection or another kind of infection. A lot of times we'll also say, if this is the first stone they've ever had, typically we recommend a one-time imaging study because we're not entirely sure, and they aren't entirely sure what a kidney stone feels like. So people who have their first stone are more likely to have something else rather than a stone, right? What about if they've had pain for more than 2 to 3 days and they still haven't passed the stone? That's indicating to me that either something has gone wrong or it's not a stone, right? So it's either obstructed, it's bigger than we thought, maybe it's infected, or it's not a stone. So anytime you're suspecting that there's a big complication, or anytime you're in fact suspecting that it's not actually a stone, this is a mimic of a stone, that's when we get imaging. Now, we have three different imaging options. Here are our three different imaging options. I want to talk to you about the benefits and negatives of each, because there's definitely one that's way better than everything else. So the first thing I got to talk about is the KUB X-ray, also stands for kidneys, ureter, and bladder. This is the oldest part of medicine. When we didn't have any other way to access kidney stone information, we ordered the KUB X-ray. That's because a lot of stones did show up on X-ray because most of them are made of calcium, right? Problem is that no matter how good we get, X-ray technology only captures about 40% of stones. And that's not really good enough for today's medicine, especially with our malpractice and everything else that's going on. Not to mention, it doesn't give us any information that we need beyond just kidney stones. So it doesn't really confirm or deny whether you have a stone. It also doesn't tell us about any mimics in case there isn't a stone. Then what do? Ultimately, if you did a KUB and there's no stone on the X-ray, you're going to inevitably end up having to do another imaging study. So why start with that KUB? Plus, it doesn't answer several questions about whether the stone is infected, whether there's multiple stones, that kind of stuff. So that leads us to a renal ultrasound. Renal ultrasounds are awesome about giving us good information on the kidney. So if you want to know whether there's hydronephrosis from that obstructed stone in the ureter, then you can get a renal ultrasound. The problem is, what are you going to do with that information? What if you can't see the stone in the ultrasound because it's too far down in that ureter? How big is the stone? Is it infected? Is there a dissection also? What if the stone is all the way in the UVJ and it's stuck there and it's impacted and it's been there a long time? How is hydronephrosis and information on that hydronephrosis going to give us any information? The answer is it doesn't. It doesn't answer enough information. Don't order a renal ultrasound on a kidney stone. That doesn't make sense. What we want to do is we want to order a CT stone protocol. This is the imaging of choice. This is the gold standard. If you do anything less than this, you're wasting your time and the patient's money. Please don't order these other two scans, okay? Get a CT stone protocol. Stone protocol is simply without contrast, abdomen pelvis. This is a non-invasive, it's actually, believe it or not, a lower cost. And because we're not ordering multiple imaging, right? It's going to give us all the information we need. It's going to show us a lot of information like the size of the stone, the location of the stone, and the number of stones. What if there's multiple, right? It's also going to be able to show us a little bit about whether it's infected. It's going to show us whether there's maybe a AAA involved, or sometimes it can show us a dissection if it's a really, really bad dissection, although most dissections do need contrast. It's also going to give me information that maybe the patient didn't know. What if we accidentally find the patient only has one congenital kidney, like that horseshoe kidney, or just one? I have found that before on patients who had no idea, and it was an emergency and they didn't even know. So it's really important, get the CT stone protocol. Now I have one more bit of information for you. I've had several of my nurse practitioner and PA and even some other colleagues come up to me and say, you know, I accidentally ordered a CT with contrast because that's typically what we do for belly pain. And I didn't think about ordering it without. What do? I think it's a kidney stone now. The answer is don't panic. A stone can still show up on a CT without. However, you really shouldn't be ordering a CT with contrast unless you're really suspecting. You're like, I think that there's other diagnoses way more likely than there is a kidney stone. If you're really thinking that your number one differential is a kidney stone, just get it without. You can always add contrast later, but you can't take contrast away. Okay. Now, the reason why a CT with contrast is kind of really difficult to tell is because the kidney stone is white, just like your bones, right? Because it's made from the calcium. And so if you put in a bunch of contrast with that and you have that white kidney stone, a lot of times it's often misdiagnosed as a vein or vessel calcification, or that contrast covers the stone as you pee it out, because it fills up the kidney and such. And so then we don't actually see the stone. Now, we can see other causes of stone around it. For example, maybe we could see hydronephrosis, and that can give us a clue to the fact that, maybe there's actually a stone there and we can't see it because of the contrast. Radiologists are pretty good at this right now. However, it's still not the gold standard. It's still not preferred because they can be missed. So don't panic if you ordered it with, but try to do it without. All right, here is my overall homemade ER approach on a stone. So I'm going to walk you through this once, and you will have access to these slides, or you can always take a screenshot. So let me start with, we have this suspected stone. So because it's a clinical diagnosis, we're going to go ahead and treat. We may or may not order a urine and a urine culture. We're probably going to give Toradol, which is the gold standard drug of choice. IV Toradol, not opiates for kidney stones. Okay. Now, obviously, if somebody has one kidney, or if they're on dialysis, or if they're a CKD patient with a creatinine of 3, typically, we don't recommend Toradol, although a one-time dose does get dialyzed out. And a one-time dose probably won't tip their kidneys over the edge, but it's still something to be aware of. Now, you can also add an antiemetic, although this is much debated in the ER world because we already know that the nausea and the vomiting that's associated with kidney stones is a vagal response to how much visceral pain that stone is causing, how much that ureter is cramping because it's being stretched and scraped. Right? That's why we have so much kidney stone pain. So they're not nauseous because they're nauseous. They're nauseous because of the pain. So if you treat the pain, the nausea goes away. So a lot of people argue that you don't need to give an antiemetic to patients with kidney stone pain, but that is something that you can decide on a clinical case-by-case basis. Now, it is something that's worthwhile to consider whether this patient needs our CT stone protocol, right? Remember all of the things that I talked about that would indicate an image. Like if you're suspicious that it's not just a stone, but maybe an infected stone, maybe it's been going on for 2 weeks, or maybe it's been a little bit different than their previous kidney stones, and you're thinking this could be something else. So in that case, we need to rule out an emergency, right? We need to make sure that it's not an infected stone. We want to make sure that they're actually peeing and that it's not obstructing their outlet, like one kidney or something like that. And we also want to make sure that they don't have a AKI or CKD. How does that happen? That happens if you only have one kidney, right? So almost all of this boils down to, do you have one kidney? Is this causing you renal failure? Could this be causing something like an abscess or an infected stone? Or could this be something like a AAA? If somebody has some kind of emergency, then obviously you need to call urology and they need to be involved. Okay. If they do not have any of these things, you got to ask yourself, does this person require admission? Now, you already know that I've done a podcast topic on this. However, if you haven't listened to it yet, I recommend it. But one of the reasons why we admit patients from the ER is intractable pain. And that means that no matter what you're giving them, opiate, Toradol, all the things, maybe they have a lot of allergies. If you can't control their pain, kidney stones really do hurt. So sometimes people require a 24-hour or 23-hour observation to try to control the pain, at least until it can come out. Or maybe they're unable to tolerate oral water. If they can't tolerate water in the department and they just keep throwing up and throwing up and throwing up and throwing up, obviously that would require an antiemetic. But if even then they still can't tolerate PO, which does happen, especially with the bigger stones that are stuck halfway down the ureter, This might require an admission because we don't want them going home and then getting renal failure due to dehydration and maybe even making more stones. Also, another one that I wanted to specifically talk about is any kid less than 1 year old that has a kidney stone is super unusual. Okay. There's something wrong. There's something genetic that requires a workup. That kid needs an admission. So if there's any of these things, you need to go ahead and admit. If you don't think this person needs admission, AKA their pain is controlled, they can tolerate water, and they're not a child, then we can either do a stone CT protocol, or we can just refer to urology clinic and discharge, right? So if the stone is really big, because we did CT them to find out if this was their first stone or not, if it's really big, then we refer to urology, or you can do a urology consult. It depends on you or ER. Either way you go, remember that a stone over 5 millimeters, you need to talk to a urologist on a phone, or at least refer them to the clinic, however your hospital does it. And if you have symptoms for more than 2 weeks, that means that stone isn't passing on its own. It's impacted where it is, and that also needs urology. Okay. If none of these things are true and they are controlled pain, tolerate PO, not a child, it's not a big stone, and it's not been going on for 2 weeks, then we discharge them, and you can give them Toradol orally or Zofran or both. And lastly, don't forget that you always need to screen for if it's one kidney or more, right? So if it's more than one kidney, like you can't have bilateral stones. Bilateral stones would require urology consult. If they just have a simple kidney stone, most of these folks are going home, and most of the time it's without a strainer. I hope that was clear. I'm sorry if it wasn't. Do better next time. Let's talk a little bit about treatment. Most of these people get conservative treatment. Most people pass in 24 hours, although, again, urology tells everybody that it could take 31 days to pass a stone. And urology, at least our services, typically wait for a full month of kidney stone pain before they start to offer surgical services. That's kind of interesting. Remember that we typically give a little bit of hydration in the ER because the more you pee, the more we can get that stone to push down and hopefully get it out. Don't forget about that Toradol. Man, it's a miracle drug of choice. Don't forget it, okay? And then you can also give the antiemetics, and we've already talked about that. A lot of urology folks highly recommend that you give tamsulosin or Flomax. This was theorized to help open up and relax that ureteral spasm and hopefully allow the stone to pass without that ureteral to spasm. I think I just said that. That said, a lot of the ER literature and even the urology literature says that this actually doesn't work like they thought it did. So they recommend not using tamsulosin or Flomax anymore. Not that it does any harm, just that it doesn't seem to help. Now, a lot of urologists are still kind of old school, and they still ask you to give Flomax. So if they really insist on it, it doesn't hurt, but it also doesn't help. Another really interesting big article that came out that was really interesting information for us is that having sex might actually help you pass a kidney stone. And as you can imagine, this is a really interesting information. Trying to tell this, especially to older patients, is pretty awkward, especially because if you're in that kind of pain, the last thing that you're going to want to do is have sex. So typically, I end up trying to interpret this information for them and say, maybe if you did a lot of walking or some jumping jacks and get that gravity going, that stone will start to come out a little bit better. So if you can tolerate it, I typically recommend some physical activity for my patients rather than overtly recommending sex. But you do you. All right. Just because I know we're not urologists, but I think it's worthwhile to understand some of the briefest and most basic treatments for kidney stones, especially because patients always ask. Urology typically waits about a week slash 4 weeks to do any kind of procedure. And there's about 3 different procedures that they recommend. So one of them is lithotripsy, which is trying to break up the stone with sound waves. Another one is ureteroscopy, where they go in and they grab it. You can see a picture of uroscopy right here. So they put this little thing up into the bladder and then they follow it up there and they look at the stone. And then right here, they grab that stone with a little outcropping and then they kind of pull it through. That seems kind of forceful and like it would hurt, but it's definitely worked. And then there's something called percutaneous nephrolithostomy with a stent. And so stent placement is very common. This is a stent, and I'm going to show you some pictures of those in the next slides here. And then this is the ultrasonic sound wave that breaks up the stone. So there's a couple of different ways. It's just handy to know that each urologist is going to decide on what he or she needs depending on the stone, the size, and what they're the most comfortable with. Let's talk about ureteral stents, because as it turns out, these things come into the emergency department all the time. So the number one most important and most useful thing that I want you to know is that stents hurt all the time. Stents cause that ureter to stay open, which allows that kidney to drain, especially if there was a lot of hydronephrosis. Even with the stone gone, all of that stretching in the backup of urine is still present. And all the inflammation, even after they take the stone out, can actually cause the ureter to clot off again. That's why we typically try not to, they try not to leave the ureter closed. They typically will place a stent to keep that ureter open. However, that ureter is recovering from all that inflammation, and it's a foreign body in the middle of the ureter. So of course, what is it going to do? It's going to cramp and spasm. When that happens, it hurts, just like a kidney stone, somewhat similar. It also might allow for all the scrapes and scratches of either the kidney stone or whatever procedure was done to drain. When that happens, the person is going to get a lot of hematuria. They're going to get a lot of pressure because it's going to feel like that ureter is filled and stretched, right? And it's going to kind of give you some dysuria because that's what a stent does. This is also increasing the risk of pyelonephritis. So a lot of patients with a ureteral stent who come in, it's really like an essential thing to get a urine. All of them will have this dysuria and the frequency and the hematuria that doesn't necessarily indicate an infection. But if they did have an infection, boy, that infection that can climb right up that stent and get right into the kidney. So they are at an increased risk for pyelonephritis. So before you ever call a urologist on a stent patient, you need to get a UA. These stents are typically left in place for about 3 months. And then the urologist typically starts removing them. However, I've seen patients who have lost their insurance and had a stent in place for like years. I don't know how they tolerated that, but it happens. So important to know that probably needs a urology consult because the stent should be coming out around about 3 months. The other thing you got to know is that we do get KUBs for these stents because these stents can migrate. Either they can go too high or they can go too low. And you can see those curly cues are meant to keep them in place. But if that starts going down the ureter, that's going to cause a very similar kidney stone-like pain. And it's going to be impossible for the patient to not get admitted or have something done. It's a lot different of a pain. So you got to ask them, has this pain been very similar since you've had the stent, or did it suddenly incredibly change over the last couple of weeks? If you had a sudden complete change, always get a KUB and make sure that stent is where it should be, because that's another complication you can have with ureteral stents. All right. Now I wanted to make sure that this list of complications with a kidney stone was very clear, so that way you understood what qualifies as a surgical emergency and what does not. So remember that the kidney stones over 5 millimeters require a call, but it's not necessarily an emergency right now. So don't be surprised if that urologist tells you, okay, just have them follow up with me in clinic. What does qualify as an emergency, even if urology is cranky about it, is if the stone is infected. So that means they have a urinary tract infection with a stone. That's important. What if this ureter causing hydronephrosis perforates and it causes urine extrave or spillage of the urine into the abdomen? Oh my gosh, super emergency. Please get urology on board. They may even say, we need general surgery right now. Okay. Make sure you know whether their belly is peritonitic or not. That is a big deal. Another one is abscess formation, either around or even inside the kidney. Bad. Abscess of an organ. Bad, bad, bad. Okay, that's probably going to require gen surge, although some urology folks will handle it, but definitely bad. Sepsis, which can result in death if we don't do something about it, that's an emergency. And then anything that would make permanent kidney damage that would require dialysis. So that's the whole one kidney situation or transplant kidney or that kind of stuff. Okay, so there's your list of emergencies. And for fun, I also wanted to point out this really weird picture that is not, it's rare, but I've seen it before. This person has 2 ureters for 1 kidney. That's super weird and kind of cool. So if they have a kidney stone in 1 ureter, it'll still hurt, but it's not an emergency because they have the other ureter to drain. Whoa, that's super cool. So anyway, just be aware that you can have a double ureter on one side. Fun. All right, this slide is just all about me recommending, and I'm not picking on urology specifically, but many consultants, especially when they're called in the middle of the night, can be very cranky. And it's important that you know that tact goes a long way. Even if people are mean to you over the phone, be nice to them because you can kill people with niceness. So please also know that just because the urologist said, oh, yes, I realize that they have a transplanted kidney stone, but I don't want to come in. If you know that this is an emergency, you still need to try and insist and say, well, look, I know this is a surgical emergency. I am not a trained urologist. What do you want me to do? Sometimes they'll say, well, I'll open up my clinic for them to see first thing in the morning. And sometimes you still have to argue with them, or sometimes you have to transfer out, or you have to kind of put it up the chain and talk to your attending or talk to one of your colleagues. But I always write down that if a urologist did not want to see that patient that day and I disagreed with it, I made sure to get a time, like the appointment time, the phone number, or the address of the office where the patient is supposed to follow up. So I can give the patient absolutely all of the amount of information and say, at 8:30 tomorrow morning at this address, you need to see this doctor. You better be there. Your life is important. Okay. This is all I can recommend because sometimes you can't, the urologists know better than us, but sometimes it's still important to be able to document in your chart that you did absolutely everything you can. Okay. So let's talk a little bit about prevention because your patients always ask about that, right? So here are some examples of causes of kidney stones. And one of the things I wanted to point out is that there's a whole bunch of different causes of kidney stones, right? Medical conditions, medications, heredity, obesity, diet, right? So here's some examples on this side of a whole bunch of different medicines that can be known to cause kidney stones, but there's more. There's so much more. So just know that you can have all kinds of diseases, all kinds of medicines, We don't really know. What we can say is that the most common cause of kidney stones, even if you're not obese, and even if you don't have the genetics to do this, or you're not on any medications, dehydration and frequent urination is really important. If you're constantly dehydrated, I don't know, like we are in the ER all the time, you need to be drinking more water, because the more that chances that all of those components of the stone have to form inside your kidney, the more likely it is for you to make a kidney stone. So highly recommend to all of your patients, they need to be drinking water. I also want to talk to you a little bit about the kidney stone diet, because all of the patients want to say, I never want to experience this pain again. So they want to know what to eat and what not to eat. So typical food products have been linked to kidney stones. The number one food product that's been linked to kidney stones the most, Diet Coke. That's right. It did take America by storm. And there are many people who exist in America who are drinking like packs and packs of Diet Coke. So the first question I ask my patients when they ask me that is, how much Diet Coke do you drink? If the answer is more than 1 can a day, it's too much. That's just my personal doctor opinion. I'm just going to put it out there. That said, they don't have to ever have drank a Diet Coke to have a kidney stone. So I also talk to them about their dehydration status. And you can find all kinds of kidney stone diets online. This is just an example of one such picture that I found using a Google search. However, it's important that you know that a lot of people have found that it's not just high oxalate foods or high calcium foods that cause it. Who is telling people that spinach and rhubarb are bad for you, right? This doesn't make a whole lot of sense. So when I did some digging, what I can tell you is that I think it's about more excess. So whenever you have something that you're eating in excess, that is what it can be causing your kidney stones. So what you need to do is you need to get a balanced diet, right? You need to be eating calcium and oxalate together in the same meal. And that is what seems to be doing the best and causing the least amount of kidney stones, along with hydration. So if you want to prevent it, here's some more information. Limit your soda, pee regularly, make sure you're drinking water frequently, and exercise. I literally have a little epic document that I have made and hand out to my patients. So I want you to know this is what we recommend. And regardless of the other pseudosciences out there, we've come a long way. Here's a couple of more statistical fun facts for you. But otherwise, that's the end of this kidney stone lecture. Hopefully we've answered all of your cause and questions of how kidney stones form, what they're like, the 4 different kinds of kidney stones, the most common cause, and what you can answer and expect if you're a patient with kidney stones.